Good afternoon and welcome to today's program titled The Fully Connected Point of Care Ecosystem. My name is Erica Randall and I'm the Content Manager for Health Leaders and will be your moderator for today's event. Our program will be 60 minutes in length. The first portion of the program is a presentation followed by a question and answer session. Please note that an on-demand version of this program will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for the live program. Today's program is sponsored by Midmark Corporation. Thank you so much to our sponsor and to you, our audience, for giving us your time and attention. Before we get started, I just have a few things to go over with you. First, to ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings or if you have PC speakers so that you have the best sound quality. Second, you will find a resources list for today's webinar in the lower left part of your screen. Here we have listed the webinar slide deck so that you can interact with it. And third, at the bottom of your console are multiple widgets. So, for example, to submit a question, you can click on the Q&A widget. And it actually might be open already and would appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note it is likely that your questions will not be answered until the Q&A portion of the program. And should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our speakers. Our first speaker is Dr. Tom Sweeterman, MBA, who is Vice President of Clinical Affairs and the Chief Medical Officer for Midmark Corporation. Our second speaker is Jonathan Bees, who is the Senior Research Analyst for Health Leaders. Thank you both, Dr. Tom and John, for taking the time to speak with us today. And with that, the audience is yours.
Yes, actually, I think we're going to start with John Bees first. I'm going to present the data from the survey, and then Dr. Tom will follow me. So first, a few comments about the methodology. This is a survey that went out in March of this year. It went out to the Health Leaders Council and select members of the Health Leaders audience. And we had a total of 105 completed surveys. And that's the base that I'll be working on kind of as I analyze the data today. Before I get into the data, here's a snapshot of what our base looks like. So here are the title sets. It's a fairly senior group. 37% are in that CEO president bucket. You can see at the top of the column at the right the kind of the titles that fall into that CEO president bucket. Clinical leadership was 29%. Operations leadership, 21%, financial, 8%, and marketing leadership, 3%, and IT leadership, 2%. So it's a fairly senior group of people. As for types of organizations, hospitals and health systems form 50%, so it's a significant chunk. Physician orgs are 23% of the base, and we have a series of smaller entities kind of filling out the rest of the 105 respondents. And for bed size, it's fairly equally distributed. I mean, 1 to 199 beds is 31%, so almost a third of the base is in that size. 20% in the 200 to 499 bed group, and 500 plus is 14%. And some of the respondents didn't have standard numbers of beds. For numbers of physicians, again, good distribution here. 13% fall in that 1 to 9 physician group, 10 to 49 is 22%, and 50 plus is 63%. And for nonprofit versus profit, we are looking at a group that is 56% nonprofit and 43% for profit. So now I'm going to get into the data sum here. The question one was, when adopting new technologies and processes, which of the following best characterizes your staff and faculty? And so 43% said that we generally wait until peers have adopted new technologies and procedures before we try to implement them. A nearly equal group, 42% of the respondents said we'd like to be among the first to try new technologies and procedures. And the third column is, according to some folks, what they call laggards. I think it's not really a very friendly term, but in any case, we generally wait until technology and processes have been widely adopted by others before we embrace it. And so I mentioned kind of laggards, but anyway, there's a, this goes back to the 60s. There's a gentleman named Everett Rogers, and he had a technology adoption curve. His paper, I think, was a diffusion of innovation. And so I thought it might be interesting just to quickly make a comparison. You know, we have just 3 items that we're measuring here in the survey, but in his technology adoption curve, there were 5 items. Those 5 were innovators, early adopters, early majority, late majority, and laggards. And if I take those first 3 from Everett Rogers' theory, the innovators, early adopters, and early majority, that totals up to 50% in his model. And so then I took our first column, of first to try, which is 42%. So we're in the ballpark. The two don't really map perfectly. But what I'm saying is I think that the results here are consistent with his model. In his model, the laggards, again, were 16%, and we have 15% here. And again, I don't like calling people laggards, but in any case, that's the term that he used. So, you know, these results look consistent with that. The other thing I wanted to quickly point out was drilling into the data. I'm kind of interested in those people who are the early adopters, the first adopters. So this is the second column. Looking into the data, interestingly, it was physician I kind of did a quick comparison of physician organizations versus hospital health systems as a group. And, so physician orgs, 46% of physician orgs fell in that early adopter bucket. And hospital health system as a group, 39% fell in that bucket. It's within margin of error for the survey, so it's not a huge finding by any stretch. But it was interesting that the physician orgs were a little more likely to be early adopters or first adopters. And then I looked at the so-called laggards, so the third column, and hospitals, health systems, 13% of them fell in that bucket, while 8% of the physician organizations did. So, again, slight indication that physician orgs were a little more willing to be early adopters and than hospital health systems. And, there are probably a variety of reasons behind that. I would expect that physician organizations, again, it's a smaller entity, maybe a less complex environment compared with a hospital or a health system, so they're able to be a little more nimble in terms of adopting new technologies. And then, Dr. Tom, I didn't know if you had some comment.
Yeah, welcome. I'm excited to be here with all of you, so thank you for this opportunity. And if I look at this slide, and it comes to me as a clinician that medicine is inherently a conservative business. Doctors are always uneasy with being the first to try something, and they tend to wait and see how things manifest elsewhere before they incorporate them into their own world. And I think we're seeing some of that into these statistics. And I think what we're also seeing in our view of the marketplace is you just are at a point now where you're going to have to start looking at technology as a way to augment your workflow and your clinical processes, because with the new demands on value-based medicine and the new data analytics pieces that are coming down the path, I'm actually surprised that these numbers aren't a little bit higher. But I do think we're going to start seeing the technology early adopters and first early majority start to become a little more interested in the technology as we go forward, as we see the power that's going to come by.
Right. Okay, good. Question 2 was, what are the top 2 goals you seek to achieve to improve the quality of ambulatory care provided across your facilities? Top item was provide greater patient satisfaction. Certainly there's been a lot of emphasis in recent years on patient experience, patient satisfaction. Note that the other responses are all in the same vicinity. So, we have top item at 51%, achieve high level of standardization to maximize consistency and accuracy at 49%, optimize and take advantage of workflow efficiencies at 48%. So they're respondents in the survey are focusing on many of the same things, and they're kind of a broad brushstroke approach. The item which stood out for me was the last bar, which was the create greater healthcare provider satisfaction at 12%. And it makes me wonder, in some ways, if this is a lost opportunity. We're maybe not recognizing that kind of the provider experience is important as well. There's some research that I've done previously where I spoke with Cleveland Clinic, for example, and they spend time focusing on kind of that provider experience, if you will, not just about the patient experience, which certainly they're very into the patient experience, but they also take into account what that provider is experiencing as part of the daily work that they do. Interestingly, again, kind of drilling into data, the number one item for hospital and health system respondents was achieve a high level of standardization to maximize consistency and accuracy. Physician orgs, it was much different. So for hospitals, health systems, at 54%, the top item, achieve high level of standardization to maximize consistency and accuracy. For physician orgs, at 71%, it was optimize and take advantage of workflow efficiencies. So, I'm guessing, it's purely conjecture, but that those hospitals and health systems are focusing on ways to take out variation and in their delivery. It's a complex environment with multiple care points, also probably much higher level of acuity. So, they live in a different world, whereas for physician orgs, maybe more about volume. There's kind of greater numbers of maybe transactions, lower acuity. So it's interesting. Again, all of this is speculation on my part, but there is a significant difference in what those respondents are focusing on. And any comments?
Yeah, I share your viewpoint on the provider satisfaction, because as most of us on the call know, they switched the triple aim to the quadruple aim with the focus on provider satisfaction. And there's a fairly substantial body of evidence that suggests that a more satisfied provider tends to be issue more improved patient satisfaction scores, as well as lower costs and better outcomes. So to me, the bottom provider satisfaction emphasis could generate positive results across the board on many levels. I too am surprised it's not higher. And to talk about your level of number 2 there, the standardization, and consistency and accuracy. I think the health systems are beginning to recognize the power of data analytics and AI and ML technologies that are going to be coming down the path. And before you can really manifest some of those benefits from that, you have to have a good data set to draw from. And so there's a lot of efforts in health systems now to clean up their data stores to make sure that what they have in their databases is something that can be utilized into something more advanced in theory. So these are interesting results, as you say. And the last thing I'll say about the provider groups having higher emphasis on workflow efficiencies, there's just a tremendous amount of overhead in the ambulatory environment. The margins are thin, and the costs of staff and the costs of workflow and efficiencies that we'll talk about a little later are just enormous. So I think those are staring some of these doctors right in the face.
Yep. Okay, good. Question 3 was, how connected is your point of care ecosystem? And you've got 30% of respondents saying that their providers have mobile devices, laptops, or tablets to connect to EMR. And 25% saying we gather a variety of data electronically to inform interactions in care management. Third bar, we have only implemented electronic medical records, so they've just focused on EMR. And we gather a variety of electronic data electronically to use to enhance workflows and processes. So then looking at the data, I thought it was kind of interesting. So take your first bar and take your third bar. There are 2 direct mentions of EMR. That's 54%, and obviously I think that's one of these maybe starting point items. But what I thought was interesting was, again, I kind of did some looking at hospitals and health systems versus physician orgs, and focusing on respondents who say we have only implemented an electronic medical record system. So just those people alone, 30% of respondents from hospitals and health systems say that, whereas only 17% of physician organizations say that they've only implemented EMR. And I'm guessing that some of it, so what it's suggesting is the physician orgs are doing a lot of different things. They're not just focusing on any one thing, whereas the hospitals and health systems, I think they're fighting a different battle. And so maybe it's about standardization and that sort of thing, and they're just going to rely on their EMR, and the environment is so complex that they're not taking it on. I'll be interested to hear what Dr. Tom thinks about that. But it basically 30%. That was the number for hospitals and health systems, and for physician orgs on that point, it was much less. So I'm guessing that, again, hospital environments may be a little more complex, and so they're maybe trying to simplify things. Any thoughts on that, Tom?
Yeah, I'll jump in. On that third bucket, on the only implemented electronic medical record, and your point that ambulatory providers are doing more than that, I think as we'll discuss in the next part of the presentation, there's so much heavy requirements, both administrative, clinically, workflow issues that happen at that point of care in the ambulatory environment, that there's a bit of a need to change the dynamic, that there are processes in place that work, but I think the physician organizations are beginning to realize that there's a tremendous amount of waste, and you'll hear later up to 40% of all tasks at the point of care are considered, non-value add, points of waste. And so I think, to me, I think they're starting to experiment, look at other ways that they can, reduce clicks and reduce bottlenecks and the like, because it really is having a material impact on their profitability.
Yep, I agree. Question 4 in the survey was, what elements of the connected care point of care ecosystem are your staff and facility currently employing with the exam room? The top response by far, so nearly over 2/3, technology that enhances clinical data management, providing patient information at caregivers' fingertips. So that's a significant element. Finishing second by a large kind of, good distance was standardization of vital signs acquisition, followed by fully connected equipment and devices with automated data entry at the point of care at 30%. By the way, that 30% matches the previous slide, where they were using laptops and iPads and the like. One of the things that stands out for me on this slide is the last row, and that's real-time locating system that identifies and corrects bottlenecks in patient flow at 16%. I would have thought that might have been higher. It's maybe that's more of a developing technology. I don't have a feel for that, but interestingly, I looked at profit versus nonprofit respondents on that one item. So just looking at real-time locating system that identifies and corrects bottlenecks, and the for-profit folks, 22% said that they were, that they were using that, and whereas nonprofit was half, it was 11%. So it might simply be a matter of these systems are expensive, or perhaps they're viewed as a luxury. I'm not sure, but there is a difference between for-profit versus nonprofit, with the for-profits participating more highly. Anything else on this one, Tom?
Yeah, your comments about RTLS, the real-time locating systems, is spot on. There's so much complexity in the hospital environment, and it's a care team approach versus a provider-patient individual approach. And so these RTLS systems are proving to be advantageous in many cases to augment making sure the right people are alerted to a situation in a room, that they're carefully monitored to see what the bottlenecks are and how they can improve upon it. It's sort of, we call it the black box of the hospital. There's you know what's coming in the door from a revenue standpoint, you know what's going out, but understanding truly what your cost drivers are and what your staff expenses are with respect to a particular patient is something that RTLS can kind of help unlock a little bit. So yeah, you're right. They tend to be reasonably expensive, and they take a commitment from the hospital system to install properly, but the benefits can be ongoing and pretty impressive. And it's a profit industry that seems to understand that there's a real gain to be made.
Right. Okay, good. And here's question 5. What is your biggest obstacle to a fully connected ecosystem? And by a fairly large margin, no budget at 54%, followed by security and privacy issues at 33%, physician buy-in at 28%, management buy-in 24%, and not a priority at 18%, and we don't have it how to start or to proceed. And the no budget, I suspect if there is ROI, then budget can be found generally. I did another deep dive here, just looking at profit versus nonprofit, and maybe it's not a surprise, but the numbers of for-profit people citing no budget is lower. It's 46% for the for-profit people, and it's 62% for the nonprofits. So a significantly higher percentage of nonprofit respondents are kind of citing no budget, and it may simply be that they don't have a budget. I mean, but again, there's a pretty clear correlation with those respondents. Anything else on this one, Dr. Tom?
Yeah, in fact, the no budget, I think, is more of a reflection that I'm not sure the value proposition, but it has been adequately, portrayed to them in a way that the ROI, to your point earlier, is really there. And I do feel that the demonstration of the added benefits with respect to patient satisfaction, provider efficiency, and clinical standardization, all elements we saw in the earlier questions, if you were to able to bring those into the ROI equation, I think this number would change. But I think there needs to be a better definition of what the fully connected ecosystem true value creation is, and I think we're getting closer to that.
Right. Okay, good. Okay, so this concludes the research portion of the presentation. I'm now going to pass the baton to Dr. Tom for the Midmark portion. And with that, Tom, I'm passing it over to you.
Thank you, John. I appreciate it very much. We just got about 15, 20 minutes worth of slides here that we're going to go through and give you a little more definition about what the fully connected point-of-care ecosystem is all about and why it matters. Essentially, we defined a fully connected point-of-care ecosystem really around making sure that everything that happens in that exam space is coordinated around the patient so that it has the optimal efficiency and that the patient and provider satisfaction levels are where they need to be. Now, that's a big statement to make, but we're going to kind of peel this onion a little bit and understand a little bit what the components are for driving some of these metrics and how we go about looking at it. At the end of the day, we feel strongly that these elements drive to better outcomes at lower costs, which is obviously the big portion of what the value creation is all about. So as we look deeper into what patients expect, I always reflect back to the fact that medicine is both a science and an art. The science portion is something I think we're intimately familiar with. We've all seen dramatic advancements in genomics and imaging and therapeutics and diagnostic tools. You know, we're the wow of the world when it comes to our clinical proficiency. What I think patients want back is some of this art of medicine, this ability for a human interaction to occur with their providers in a way that is exceptionally meaningful. In fact, when you look at the research to look at the whole care journey of the patient from symptom all the way through therapeutic outcome, when you identify what are the value creation steps that are involved, they consistently point to the time with the provider as being the most value-added time in their whole journey. You know, of course, scheduling an appointment, waiting in a waiting room, those don't add a lot of value. But when you spend that time in front of a provider who is listening to you and hearing your concerns, it has an uninterrupted experience, can be extremely valuable to a patient. And what's reassuring is that the providers want the very same thing. If you outline what they seek in their professional satisfaction or professional, enjoyment, it's really around having the time with the patient that they want to have, that they can properly address the patient's concerns and issues in a meaningful manner and avoid the bureaucracy of medicine and all the pieces that go with it on the business side. I don't think it's a coincidence that the American Academy of Family Physicians has identified first out that reducing bureaucracy at the point of care is their number one mission now, to help these doctors, consummate that visit in a way that's kind of the way it was, 30, 40 years ago, where all this technology is sort of didn't exist or certainly did not interrupt the doctor-patient interchange. Now, I'm not advocating that the technology is a bad thing. I think it's exceptionally powerful, but we've got to find a way to bring that technology into the room and hide it. In other words, make it semi-invisible to the care exchange, but leverage all the power it provides you. So if there's data generated with the patient, finding a way for that to automatically find its way to the electronic health record or to the analytics platforms. If there's technology that requires connectivity, that connectivity to the EMR to drive the device of some sort happens automatically, and it's something that's seamless. At the end of the day, what we find, as I said earlier, is when providers are satisfied, they tend to deliver on the bigger mission goals in a much more profound way. They tend to be better with their patients. They tend to be lower costs with better outcomes. And the next slide kind of points to this. When you interview, this study was done just this year, and you find out what is it that is making providers the least satisfied in their work. And they're finding that this bureaucracy of data and tasks that are administrative in nature are really inhibiting them in their care delivery with a patient. These numbers are really quite staggering. 40% of doctors admitted to the survey that they were less engaged with their patients, and then 32%, a third of the doctors, acknowledged that they're less friendly. Now, if we go back to this whole science and art concept that medicine effectively delivered as both a science and an art, you really have a trouble to rectify any sort of effective care delivery when you aren't friendly with a patient. When I started practice, my dad took over for him, and he gave me some pretty sage advice. He said, when you start your practice, you're going to be thrilled with the technology and the science that you have in your brain and how you can deliver that effectively. As you go forward, you become much more aware that it's the relationships and it's your ability to influence people that becomes very meaningful and impactful. And he was exactly right. And I think doctors right now are craving this back to purity model where they can actually have this care interaction that is both meaningful to them and their patients. And that's what they ended up going to medical school for in the first place. So as we look at some of the barriers that can lead to this dissatisfaction, one that's consistently pointed to, and I'm not sure it's coming across the slides very well, is the fact that the electronic health record is a consistent barrier between a doctor and a patient. We know the EMR is a requirement. We know the data gathering that comes from the electronic health record is essential to the care delivery. But somehow this technology infusion into the exam space is being consistently seen as a barrier to this interchange. Lehigh Valley did a study before and after their implementation of the EMR, and I was surprised to see that a significant number of patients, I think it was close to 20 to 30% of the patients, outright said that the EMR introduction encumbered their exchange with the doctor. So I think it behooves us on the call who are really responsible for as stakeholders in this exchange that we look at this environment and really think of how can we possibly take this new digitization element and create an environment that is both intimate and effective at the same time. So as I said earlier, bringing back some of those art elements that I think we're missing from the past. So when you look at what the benefits of a fully connected ecosystem can drive, you really got to think about all the elements that happen when a doctor or a provider and a patient have an exchange. The data that comes in and out of the room needs to be managed thoughtfully. Every click needs to be examined in a way that's carefully analyzed. Can we reduce that click and can we eliminate it? Things like motion where the patient has to move from point A to point B, or the doctor or the care team has to move across the office to get something done. Really looking at all the elements of how that doctor and patient exchange happens. One thing I advise people of care delivery nature to do is something called a Gemba walk. A Gemba walk is a lean term where you actually take off your administrative responsibilities or clinical responsibilities and you walk through your facility as if you're a lean consultant or a patient and looking at the efficiency and observe how far your care teams are walking from one point to another. Analyze how many times a doctor is waiting for information that should be at his fingertips. As we saw earlier in the research slides, that data at the fingertips is one of the highest priorities of interest that the respondents that they're looking for. So at the end of the day, this is all about boosting the experience between both the patient and the caregiver. And as you go to the next slide here, you can see that 40% of the office work that is done is redundant or wasted. And I think, I know we have a lot of care providers who work in the ambulatory sector. I don't think this is a surprise to many of you. When it comes to scheduling or rev cycle or documentation, the amount of ancillary staff that's required to do some basic tasks can get quite burdensome. And I like to flip this 40% out of being just considered a waste. And sure, every 5 or 10 points you reduce on this 40% is going to have payback. But flip it and think about the opportunity cost. This 40% to me reflects why the caregivers are getting burned out. Because if you think about all of this administrative work that's been sort of projected into this care space, a lot of it came from the new technologies, the new coding requirements, the new formulary requirements, and go on. Whereas 50 years ago, there wasn't that level of outside influence. So the opportunity cost of this 40%, I think, is remarkably high. And I think we need to take, as care teams, look at all of these elements on the left what can we do to maximize that point of care experience to take the waste out? Clicks and bottlenecks are things that I feel are like synergistic with each other. If you're able to automate a clinical task up front, you have the opportunity to sort of tackle 4 or 5 birds with one stone here, because you have the opportunity where you don't have to do a process at all. And we're going to talk a little bit about that as we go into some of these areas of waste. Another way to look at this 40% is its tax. It's tax on your operation. And everybody who pays taxes, all of us on the phone, try to minimize their tax exposure. This 40% is a tax on your operation. And when you're dealing with single-digit margins, often low single digits, it's this 40% that's going to give you the ROI. So as you look to the point of care, it is one of the more complex areas of workflow, not just in medicine, but also across industries. You've got a very human element where the aesthetics and the design influence how a patient's going to react to their care teams, how they're going to feel comfortable providing the information about themselves. You got the technology and devices that have just exploded here in the last 10, 15 years. There's all new capabilities that are brought into this space. There's data elements that have not been seen before. We now have Fitbits and Apple Watches and all kinds of remote tools that need to come into the decision trees. And then you got ergonomics and safety. A lot of us on the phone may not realize that when you look at OSHA statistics, ambulatory care provider teams like nurses, MAs, have some of the highest injury rates from trying to lift patients to put them in a proper position. It's not exactly an easy type of work, not just from the cognitive side, but the physical side. It can be very, very burdensome as well. And it all boils down to this interaction piece that needs to be patient-centered. So when you think of this, I think of a balloon. You squeeze one side of the balloon. If you work only on the aesthetics and you have a really elegantly beautiful design system, you're probably going to cause some deficit in the technology or the clinical side. If you focus on what's in the clinical, you're going to have patients. So you have to think of these in concert. And this is why we use the word ecosystem, is that no one element dominates. They all work together in a critical way to drive the efficiency of care that needs to happen at the point of care. And to do that, we look at lean. The lean philosophy is something that has been vastly deployed in manufacturing. And I don't want to come across condescending, because certainly the clinical environment is not a manufacturing environment, but the categories of waste do apply quite nicely to what we're doing here at the point of care. Overproduction is something that I know we're all working with. Could we see these patients remotely? Could we incorporate a telemedicine solution so that some patients who are routinely being seen could be handled remotely or through an alternative medium? Could we reserve that space that's so critical to care delivery and keep it for those who really, truly need to be there? Waiting is another one, whether it's a patient waiting in the waiting room or in the exam room for a doctor to be seen. We talked about RTLS being able to help with that, optimize the workflow so that there's minimization of waiting. But it's also on the provider side. You've seen many times in your own operation where a provider doesn't have the information he needs to create a decision. And so the doctor has to call for the x-ray results or the lab results. These are all elements of waste that just dovetail or have a long tail to creating waste downstream. Motion is moving patients in and around the exam room. We feel strongly that a patient should be at the center of the experience, not just mentally, but physically, that point of care at the exam chair is really where that patient should reside in a comfortable manner, so that all the environment around that patient can be managed so that those needs are met in a very predictable and reproducing way. Overprocessing. This is one we're going to talk about along with number 7, defects. Are there things you do in the clinical realm that are just not a value add? Are you adding elements to your diagnostics or in examination pieces that really don't need to be there? Or are you doing the wrong thing? So when it comes to defects, when you have something done at the point of care that's diagnostic in nature, it has to be precise. It has to be accurate. We saw that in the for earlier statistics where the health systems understood that the data integrity that you're achieving on your results have to be actionable. You have to have the doctors able to do some activities related to the care journey on the patient from that data. So as you look at these areas of waste, I think if I had a care environment that I was managing, I would very much ask some of these types of questions. Where can I eliminate waiting? Can I get the doctor the information he needs now? Can we predict what that doctor is going to need so that when they're at the point of care, everything is provided for him so that we have a one-stop in and out experience where the patient gets their therapeutic outcome without having to either wait or come back? Can we avoid motion? Can we center the patient in the room and have all the care delivery elements surround that patient in an effective manner? And can I eliminate diagnostic defects where when I know something's done at that point of care, it's of enough clinical validity that I know we can act on it and make a decision on the care journey at the very moment. And we're going to talk about this a little bit further as we talk about some of the opportunities we have on these categories and how technology might help with this. So the next slide, you'll see that we think there's a real benefit to standardize the critical activities. In lean methodology, this is called standardized work. It's very repeatable. Now, the ambulatory environment can be anything but predictable and can have a tremendous amount of variability, but there are elements of that care that is absolutely done on a very, very consistent basis that can be optimized in a way that you know they're going to be done right every time. In addition to that, if you standardize your critical activities, you can get your whole organization sort of aligned around best practices, the ones that rely on evidence-based guidelines, that have the least amount of clinical waste involved, that you're doing the most important things up front, and you're saving the more expensive things downstream for only the times that you really need it. So MACRA and MIPS type of incentive programs give you the opportunity that if you are successful standardizing and getting good outcomes, you're going to get rewarded on some of these bonus programs that are in place. We're going to take just one called that we focus on blood pressure. Back in 2017, the New England Journal published an article called the SPRINT trial. And the SPRINT trial really was a massive study on blood pressure and what happens when you lower the blood pressure from 140/90 to 130/80 or less. And what they found was that the outcomes were profound. We're talking 25 to 27% reduction in cardiovascular events, a dramatic reduction in all-cause mortality. The American Heart Association followed up very soon thereafter and reissued the clinical guidelines for blood pressure and said that every care provider should be attempting to get their patients to 130/80 or less. What's different about this that I've not seen in my career at this level is they didn't just care about what the numbers should be. They absolutely focused on the how. They recognized that the precision required in order for doctors to do this effectively is of a higher nature than what they have experienced in the clinical past. So they actually stipulated very clear guidelines. The feet need to be flat on the floor, the back supported, the arm and heart height. The patient should be rested by at least 3 minutes. Their bladder should be empty. Nobody should be talking. Ideally, the patient should be alone. And if you have the opportunity, you should be doing 3 blood pressures and average them into a single number that is the actual resting true blood pressure. So the American Heart Association really focused on this reduction of defects at the point of care. Can we get that blood pressure at the point of care to be something that's actionable? And the reason they're so focused on it is by reducing from 140 to 130, 30 million more Americans were classified as having elevated blood pressure that is problematic in nature. And when you add 30 million people to a roll of disease, you have to be extremely careful of false positives. And this goes into this overproduction thing. So if any one of these elements you see on the screen are off, there's clinical science to suggest that there's a 5 to 10 point elevation in your blood pressure as a result. Legs cross, for instance, or you're talking during the exam. Those 5 or 10 points could be profoundly impactful on your MACRA and MIPS scores, and they could lead you to false risk identification of a patient. So this is an example where a connected point of care ecosystem kind of focuses on a clinical standard and produces the environment so that this test can be done properly the first time in a way that's actionable so that you don't have misdiagnoses, repeats. That every 5 or 10% of patients you misdiagnose with blood pressure, you're going to have 10% more labs, 10% more follow-ups, 10% more complications, and the list goes on. These are where the big buckets of efficiency come from, is when you can really know that what's being done at that point of care is going to minimize downstream effects. We talked a little bit earlier about RTLS and real-time tracking. This is a way to change the traditional doctor-patient relationship that has been in the environment of care delivery forever. We're now moving to a care team where it's not just a doctor. You got a nurse, you got an MA, you got a clinical advisor on diabetes, you have your pharmacist at times. It's really important that all these efforts are coordinated, and you're also reducing the waste that could come from any type of inefficiencies that gather. An example of an RTLS setup is on the screen here, where you know where all of your care team is located. You're tracking their locations, you're tracking the time. You're able to discern bottlenecks. Where are the biggest barriers to my efficiency coming from, because you have data to validate it. Perhaps you're having inefficiencies on a particular procedure, or you're having inefficiencies in a particular staff member. You can start analyzing where some of these elements are coming from and start taking advantage of it. Also, if you look at the color coding, it also is an automatic queuing for your workflow teams to know that exam room 3 or exam room 8 in this condition needs to be cleaned. And nobody has to do any communication. It's just an automatic, look up at the board. We know that room 8 needs to be cleaned. It's just reducing one of those steps, one of those communication scenarios that is needing to be attended to. And finally, I think the payoff for a connected care ecosystem is certainly here and now. I think the boost of efficiency and the reduction of waste and the ability to boost the patient experience have true material benefits that are absolutely something that health systems could enjoy today. But I really think that the environment that you would set up for that is going to pay you even much bigger dividends downstream as we start seeing this new AI and ML systems come to play, machine learning. We're going to be able to do really powerful insights to patients, understanding what their clinical drivers are beyond just a lab test or a question and answer series in the exam room. We're going to know about their social determinants of health, their genetic profiles. We're going to know about complex subtleties to imaging studies. All this is going to be another layer of information that's going to find its way to the point of care. And if you are building the infrastructure for doing this today, and you're able to capture data effectively, manage it at the point of care effectively today, this next transition is going to be something that's going to be a reasonable step for you to take. And if we don't have efficiency today, and you're still sort of operating in an older traditional model, these new technologies are going to be very difficult to harness. And in my way of thinking, this is really where the true efficiencies of medicine are going to start becoming very powerful, that we're going to have, again, new clinical insights. And going back to the art of medicine, my ability to know you as a patient goes way beyond what you're telling me in the exam room. I'm going to have this whole circumstance sort of outlined for me in a digital manner. So to me, the connected point of care ecosystem is almost, in the next 2 to 3 years, a mandatory transition you should take in order to put yourself in a position to adopt some of this newer, later generation technologies. So I'll conclude with that, and it's been an absolute pleasure talking to you, and I look forward to the Q&A session.
Wonderful. Thank you so much, Dr. Tom and John. What an excellent presentation, and just so many good things for us to think about regarding this. So yes, you are right. It is now the Q&A session, and I'm just going to give the audience some instructions before we go on. I'm inviting the audience now to ask live questions of our speakers. And in order to submit a question, please click on the Q&A widget at the bottom of your screen. As I mentioned before, it may already be open, and if it is, it would appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewable by other audience members. So I just wanted to mention that, and as we're waiting for people to write in their questions, I just wanted to mention or make a comment. Health Leaders wrote a cover story recently that I think delves nicely into the topic that you presented here, especially about how a functioning point-of-care ecosystem can enhance the revenue cycle. And in the cover story, it mentioned the multi-specialty hospital called Magnolia Regional Health Center, which is in Corinth, Mississippi. And they used technology in order to streamline their process and revenue cycle to help in the registration area of their patients. Not only did it help the health system be more patient-centric, but it helped streamline how, so that patients didn't have to wait in order to pre-register. They would pre-register over the phone, and it really, the technology that they used classified patients into 3 categories and allowed the desk clerks to be able to have everybody pre-populated and ready to go when they needed to advance into their services. So just thought that was a nice connection there. Okay, let's see, let's go to the Q&A and see what our audience is asking. All right, so Dr. Tom, this is for you, and you really did touch on this, but I just wanted to know if there was any other or additional thoughts that you might want to focus on. One of our audience members has asked, given the goal to achieve consistency, accuracy, and workflow efficiencies, do you see lean initiatives as a good tool to affect change? And I just wanted to know if you had additional comments on that.
We've actually used lean theory and a lot of our engagements to help optimize workflow. I absolutely do. I think that the lean concepts need to be held at a 30,000-foot level, and you have to really look at them, the clinical lens, and adapt them to the clinical environment. I think standardized work is probably not the right term to say to a provider about what he does, and you want to avoid getting classified as something called cookbook medicine, where you just follow a certain set of rules. Lean can be very rigid, but if you look at lean from a conceptual level, it's sort of a philosophical level, it absolutely can be of great value. And I also find this idea of continuous improvement that's inherent in lean as being something that we all should adopt in clinical medicine. I think there's a lot of stickiness to how things are traditionally done, and there's a reluctance to try new things. And I think with lean theory, it really pushes you out of that corner and says, look, you need to be trying new things all the time. And as long as you're doing it in a controlled fashion and that you've got some thought behind it, I think you'll find that each little step becomes, as I said, synergistic to the overall goal. It's not 1 + 1 + 1 = 3. It's 1 + 1 = 1 = 8. You'll see, I think, leaps where you're actually eliminating whole pieces of work that you previously were doing that did not add value.
Great. I thank you so much for delving into that just a little bit more regarding lean. So I hope that answered the audience participant's question. Also, we have another question that says, does the RTLS automatically display summary of activity?
Yes. RTLS has that benefit of time stamping with it, that all the data of workflow is securely stored in a manner that can be reviewed and analyzed with some depth. You can see your average times, typically in a good install where the groups are engaged and they're adopting the technology with an active nature. You can see how long your waiting times are, how long your patient visits are, what kind of other metrics. We did a trial of this in an office in Ohio, and we installed the RTLS, and we were clever enough that we asked the staff what their predicted times were for particular activities, rooming time, patient wait time, and these types of metrics. And we carefully recorded those, and then we unveiled the actual numbers that came from the RTLS. And I was quite astonished by the level of error that was in what the care team thought the times were. As an example, they thought patients were typically waiting, no more than 10, 15 minutes in the exam room for a provider. And we showed them a graph that demonstrated that at many, many times during the day in a repeatable fashion, patients are waiting as much as 45 minutes. And then we added on that 6% of the patients in one particular day were leaving the office, prior to being seen because they got so frustrated. And one of the data points we had earlier in the conversation was about physician buy-in. If you ever want physician buy-in, you show them the objective data that is non-arguable about the actual process times and process frustrations. And like the data scientists they got incredibly engaged very quickly because they could see where the waste was coming from, and the embarrassment factor sort of kicked in that, wait, my patients are waiting 45 minutes for me. That can't be. So not only does it give you that, but it gives you an objective tool. It's no longer opinion or guessing. Here it is. Here's what's happening in your environment. So it can be a very powerful tool for change management.
Excellent. Very thorough answer to that question. And then the other question that has come in is, how does the point-of-care ecosystem enhance provider satisfaction? We saw that statistic at the front of the results in the presentation, that it was about 12% that providers, the priority was not there for provider satisfaction. So could you tell us how it could enhance provider satisfaction?
Yeah, I'll start with a story. We had to do some research on a topic, and so I went to the American Academy of Family Physicians show, and I just started talking to some of my fellow docs. And very soon after that, third or fourth person I was talking to, a physician, I found myself in sort of a counseling mode because they had a lot to say, and they were quite upset about it, and there was a lot of elements of burnout. You could just feel it in their voice. So I think these statistics around physician-provider burnout and frustration are real. And I think there's unfortunately too many doctors leaving the industry out of this new administrative burden requirement and all the rules that they have to follow. So to me, to my way of thinking, we're going to have a heck of a hard time getting from where we are on a cost basis for the U.S. health system into something more value-oriented, where we really are helping patients with change management, with their social determinants of health, getting influence to them. You aren't going to get there unless the people at the front lines, the physicians, truly feel like they have the opportunity to do that. So to me, it's a mission that we open up this primary care exam room, and it's something that allows them to get to that point. And I think we should be looking at the next generation of technology not to add things to the room, but take things away and make the doctor able to provide that care experience. And the providers have over and over again demonstrated that when they're satisfied and they're engaged and they can lead to activated patients, again, all the downstream issues and benefits that come from that are both tangible and intangible. There's true cost measures, but there's also elements that your health system branding is going to come off stronger. Your physicians are going to be more engaged. They're going more adept to help with some change management. So I'm passionate about this topic because provider satisfaction to me is really where the ball games should be played right now to start the process of really getting patients to be engaged in their health.
Yes, agreed. Well, thank you so much. This is really all the time that we have today, but I just wanted to thank you again, Dr. Sweeterman and John Bees. Thank you so much for your excellent presentation. Thank you to our sponsor, Midmark Corporation, for making today's program possible. And finally, thank you so much to our audience for participating today. We hope that you'll join us in the future for another Health Leaders webinar. And with that, this concludes today's presentation. Have a wonderful day.